Friends, ladies and gentlemen, welcome to CME number 794. I welcome Dr. S K Mathur sir to elaborate on the metabolic aspects of this great combination of dapagliflozin and sitagliptin. Very few slides, sir will double up as a moderator also, and I would request all of you to please keep writing your questions and direct all of them to Dr. Viveka sir. Dr. Mathur sir is only for moderation, not for answering your questions.
Thank you so much, Sushi, that you saved my life. As it is that I'm not there to anyway, thank you, Sushi, for giving me this honor to speak in front of this August gathering. And I'm very happy to be back after 3 months of sabbatical without practice and back home in the workplace. Thank you. The task given to me today is to share the slides of Dr. Baglu. Unfortunately, he was not there. There are so many slides, but I shared. I'll pick a few slides which I can share with you all, and then the rest Dr. Tulsi will take over. So all the best for you. Today's topic is combination therapy in type 2 diabetes, dapagliflozin and sitagliptin. SGLT2 inhibitor and T2DM inhibitor, the combination is very popular. It's been talked about. Now, Dr. Baglu has divided his talk into 4 stages. The first one, why combination therapy is required in type 2 diabetes. Metabolic dearrangement in the type 2 diabetes. The role of SGLT2 inhibitor and T2DM inhibitor in the management of diabetes. And using the harmony of these two this combination. So this is what he wanted to talk about. There are a lot of slides in the armament of Dr. Baglu, but I will not be able to dwell upon them because they are too intricate for me. There are a lot of studies and all being talked about. Why do we need combination therapy? That's the first thing is that. Now, as we all know, natural history of type 2 diabetes is a progressive process. It progresses. It goes on, there is no cure for diabetes as we all know, it has to be controlled. So earlier control is better. This one slide is showed IFT and IGT, impaired fasting glucose and impaired glucose tolerance in diabetes. When they start, it progresses fast. If you see the slide that in the next 5 years, the impaired glucose tolerance become over diabetes. And the fasting one also becomes over diabetes over a period of time. When you go and see the cause of diabetes, there are 2 main causes. Insulin resistance and insulin level deficiency. If you see the insulin resistance remains throughout the level same, it doesn't dip so much. Whereas the insulin production of beta cells goes down gradually and goes very slowly. So this is an important point to understand that insulin resistance is there, will remain, but insulin availability goes down and down. Now diabetes status in our country, this is the important thing to understand. More than 89 crore people are diabetic in the country. There was a study which was published in February 2022, and prevalence of diabetes is 8.3%, which is very high number. Total diabetes cases about 74 million. I hope this study is wrong. There's so many diabetic cases. 1 out of every 7 adults with diabetes is from India. It's another bad news for us, but nonetheless it is there. So what does it mean? There's a study we did, TIDE study shows a large percentage of patients with type 2 diabetes and sub-optimal glycemic control is a real towards meaning by that diabetes load is very high in our country, and the control of diabetes is not achieved as well as we expect out of it. The one study, the TIDE study shows the 76.6% poor glycemic control. The Mathur presented DSSDI saying that 76%, more than 70% are not under control of diabetes. Whereas microvascular complication, which is early complication, is 35.7%. So complication setting in early and number of complications going up. So this need to control diabetes rather early. Next. Diabetes status in India, only 36% of steady population achieved glycemic control. The number of SPA which is high is in few states in the northern part, Punjab, Bihar, Chandigarh, Haryana and Karnataka. These are the states that say the higher value of HbA1c at the time of diagnosis. Here I would like to share again Asian Indian phenotype, which we all are, and whether we stay in India or outside, are more prone to develop diabetes or cardiovascular complications. Increased abdominal obesity, visceral fat, increased ethnic genetic susceptibility. That is one important point which we all know, that we are prone to develop diabetes. We have increased our ethnicity to develop diabetes. Decreased adiponectin level, increased inflammatory markers. These are also pro-markers for diabetes. Low BMI threshold for diabetes, lower age threshold for CV. This is an important point. Earlier, less BMI diabetes are there, and the CV incidences are rather early. Dr. Viveka knows better than anybody else. The younger the people are getting cardiovascular events in our country than anything outside. Increased insulin level for onset of beta cell dysfunction. Increased atherogenicity, dyslipidemia, increased consumption of unhealthy food, and faster progression from pre-diabetic to diabetic that we showed before. Means Indian population is more prone to develop diabetes with all these factors. Another point I want to add, our lifestyle is a more on sedentary side basically than active side. So we are more prone to develop diabetes early and cardiovascular event early, to be guarded, and our family physician, we have a supersonic family physician with us who can guide us how to treat the diabetes early and take care of them better. Now, Dr. Bagnu also divided 4 clusters of diabetes patients in the overall group, how to tackle these patients. The first group is severe insulin deficient diabetes, SIDD. About 26% patients, lower BMI and waist circumferences, lower C-peptide and low insulin secretion, highest A1C levels, more likely to require insulin, high risk of developing retinopathy. This is more in type 1 diabetes, but these are patients who require insulin therapy rather early. So we pick them early. Second group is insulin resistant obese diabetes. This is also not uncommon. About 30% of the patients, highest BMI and waist circumferences, highest C-peptide, high insulin secretion, A1C level is intermediate, more likely to be on metformin, high risk of developing CKD. These two groups is important, that one is more developed retinopathy, means microvascular, because CKD is also microvascular. These groups are also developed. Combined IR and deficient diabetes, the two groups combined, about 12%, younger age group, BMI and waist of intermediate, A1C value is poor, lowest SGLT2i and highest TG levels, about 15% on insulin, high risk of developing CKD. And last group is mid-age related disorder or diabetes. About 35% older age group, preserved insulin secretion, A1C levels is moderately elevated, SGL is high, least requirement for insulin. So why he divided 4 groups? That this gives us just a guideline whom to treat and how to treat. So that is what Dr. Douglas would probably was saying, he would have explained better. I just thought to share with you. Now, need for combination therapy in type 2 diabetes, progressive nature of type 2 diabetes as we have learned before, suboptimal glycemic control, common and widespread problem, 46% do not get A1C in the goal. Several pathological processes contributed to hyperglycemia. Single drug cannot reverse all metabolic arrangement. This is what the studies have shown. Combination and co-formulation of new strategy of drugs increasingly being accepted and recommended by guidelines of American Diabetic Association and American Association of Clinical Endocrinology to achieve the rapid glycemia. So this is what is we talked about, is that all these factors promote us or say guide us to give the combination therapy rather early than later. Now the second part that Dr. Ramon wants to share is the metabolic disorder. This slide is very common, which we all must have seen time and again. Metabolic dearrangement in type 2 diabetes, increased lipolysis, decreased incretin effect, where we come the DPP4 inhibitors role, increased HGO, neurotransmitter dysfunction, decreased glucose intake, increased glucose reabsorption, SGLT2 inhibitors are now coming big way, increased glucagon secretion and decreased insulin, high state of beta cell. So all this 8 octangle control, Chavan has taught us many times. This is increasing hyperglycemia. Now the hyperglycemia has to be controlled. How best to control? We have to work on that. Now I skipped many slides on Dr. Wagner, which gives how SGLT2 inhibitors act, how the T4 inhibitors act, and the various studies which I talked about, which I think I am not the right person to elaborate upon them. From the glucocentric approach, patient-centric approach, what has been talked about, how to tackle a diabetic patient is not only to control the sugar level, it has to control the overall aspect of the patient, how he grows future in life. So in that they call lifestyle measure, healthy diet and regular exercise, the most important part of treatment of any metabolic condition, irrespective of diabetes, hypertension, dyslipidemia, I can talk hyperthyroid also. They should do a lifestyle measure which is very seriously to be communicated to patient by a physician who is treating him. It is required a few minutes of pep talk to the patient to motivate him to follow the lifestyle measure in a very earnest manner. What is the position of metformin? Is there no contraindication? Remain first because as we all know, metformin is the hallmark of treatment for diabetes in time to come. Selection and added therapy of the metformin depends on the number of variables. This variables, Dr. Wagner want to share with you all. What is the target glycemic control? What do you want to achieve with the particular patient? Age, duration, diabetes, how long the diabetes is, presence of CVD, I mean all the comorbidities along with the diabetes is important to treat the patient. Renal function, EGFR is again guideline how to give, but to give medicine is important. Obesity, overweight, underlying comorbidities, CAD, heart failure, pancreatic disease, Viveka will add on that. Cost of drug are cheaper, generally available, not. These are the social factors which also be kept in mind by prescribing medicine. Because the cost is also very important. You try high cost drug, patient may take for a few months and then he is without drug. If you prescribe the drug which he can afford for long, because it's not going to be cured. It is going to stay for the rest of his life. So if you can control the, guide the patient what drug to be taken, it can take for longer time. There are various other guidelines, I am not going to tell of that. They require a lot of elaborate studies which Dr. Tulsi can elaborate more than me on this front. Now, choosing second and third line therapy, SGLT2, GLT1 receptor inhibitor, sulfonylurea, most commonly being used in our practice, as I know, is second line of therapy sulfonylurea along with the metformin. DPP4 inhibitors increasingly prescribed now. It has become very popular drug. The cost has come down. A lot of people are prescribed DPP4 is faster. Pioglitazone may not be preferred for weight gain. Only both high carbohydrate is also a drug you have tried in a lot of obese patients or those who can afford it. Now, I would like to say dapagliflozin, sitagliptin combination should be preferred. Why? Because this is the CME organized by the people who want to market this drug. So I must talk about the slide we shared with you. Rational combination with the complementary action of 6 out of 8 pathophysiological mechanism of type 2 diabetes. Proven safety and efficacy of both drugs among their drug class respectively. Additional benefit in high-risk group prior ASPCUD, heart failure, and CKD. Pharmacokinetics appropriate for OD dosing, but this drug can be given once a day, which is more effective. And vitagliptin based FDC should be used PDM and all this compared. But this drug can be given a single dose, which is there also highlighted. Documented CVOT cardiovascular outcome trials for both the drugs. Linagliptin, ribociclib do not have it. So we are highlighting is an important drug than other combination which they want to give. Both drugs backed by the large number of research papers and widest worldwide clinical experience, which Dr. Wagner shared in the slide there. No dose changes, 10 to 100 required in most of the patients with a mild to moderate renal and hepatic impairment, which form the majority of typical clinical practice. This is again important for the compliance. Drug doesn't require many changes, can be given same dose. Combination with the evidence of long durability of glycemic control with the individual drug. So they are given the importance of this thing. I think I appreciate this is seen on the ground when we prescribe the medication. What dapagliflozin sitagliptin combination should be avoided? When should be avoided? Type 1 diabetes, as you know, pregnant and lactating women see the CKD. Remember, sitagliptin dosing reduction is mandatory. Prior history of acute pancreatitis, all DPP4 inhibitors should be not given the pancreatitis patient. Acute hospitalization, situation, severe infection, all those things you all know. Prior episode of frequent severe complicated urinary tract infection. All SGLT2 inhibitors should be given the real caution. Recurrent genital fungal infection, prior history of amputation, PVD, diasporic ulcer. Plant need for long-term indwelling urinary catheter, prior history of decade. So these are the conditions where we should be cautious to combine the fixed dose combination of sitagliptin and dapagliflozin. Now, to summarize, though I have hurried up the talk, but to summarize, SGLT lowering does not significantly reduce the cardiovascular risk or mortality, as we all know. Obesity, hypoglycemia avoidance, and CVD risk reduction also need carefully consideration. Dr. Viveka is going to highlight how to reduce the CVD complication. Reducing micro and macrovascular complication and improving the cardiorenal outcome have gained a critical importance in today. So this is one point which I want to highlight, the microvascular and macrovascular, both complications can be reduced if you control the diabetes rather early. Metformin remains first line of therapy to which other drugs can be added. SGLT2 inhibitor, DP4 inhibitor combination can be considered as early addition to the metformin in patients with inadequately controlled hyperglycemia, A1C more than 8, with all this comorbid condition. So to summarize what they want to convey, the one who would have been better is that we can use these combination therapy rather early than wait. If the HbA1c is more than 8, we should not hesitate to use these combination drugs. And I would like to finally thank you for that. Thank you, sir.
I think friends would agree that Dr. Mathur being the true master.
Come on. Very well.
I remember an expression called, he has taken it like a duck to water. So honestly speaking, we didn't feel the absence of Dr. Manglu sir. That is the good news. The bad news Dr. Tulsi has just announced is that I am supposed to be answering all the questions with you in the end. That is a very, very tough answer. Anyway.
Can we reverse it?
Reverse it means, sir?
He should answer.
Yeah, he should answer all the questions today. Yes, good one. I would request Dr. Mathur sir to take to the role that he was originally assigned to moderate the session now for Dr. Viveka sir. Friends, we know, and I mentioned it in my initial introduction, that one thing on which all the DPP on all the SGLT2 inhibitors agree is their great advantage on reduction of hospitalization on account of heart failure, their great advantage in reducing heart failure, and actually now SGLT2 inhibitors have become an established paradigm regimen of heart failure therapy. So you have diuretics, you have beta blockers, you have MRAs, and you have ACE and ARBs, and then you have SGLT, and then you have ARNI. Okay, so you have so many things now. SGLT2 inhibitors have become the cornerstone of heart failure therapy, and actually Dr. Viveka once mentioned in his talk that SGLT2 inhibitors are as much an endocrine drug as they are a cardiac drug. So we don't know which is more, whether it should be called a cardiac drug or it should be called an endocrine or a metabolic drug. So such is the wide usage of SGLT2 inhibitors now across spectrum of medical conditions. To highlight on that, Dr. S K Mathur sir will introduce our honorable speaker, Dr. Viveka sir, best friend of our forum, Physician Forum of India, and he will also introduce the topic. Over to you, sir.
Good evening once again. Dr. Viveka, as Sushil said, he is a friend of Physician Forum of India. He really don't need an education from
Best friend, sir.
He is the best friend of every one of us. The one USP of sir, one call returns call back in no time. So that is a great sir. We compliment you for that. He is so kind to all of us at all times. Sir, there's a thing in all of you, so you know, I don't want to highlight so much of thing about you. You are the best, sir. That's the one word I can say. He is so proud of you to be associated with us. And I don't think that all these things required to talk about you, what all you achieved in your life is commendable at every step. Starting from your MBBS days, then your IES days, all those things commendable. So we are so proud of you, and we request you to come in the platform in cardiorenal metabolic care with the SGLT2 inhibitor, sir. Welcome, sir. Very difficult to add some comments. You are the best.
Well, so good evening. A special thanks to Dr. Mathur and Dr. Chauhan for introduction, and special thanks to Sun Pharma. So they told that the today's topic, I think Dr. Mathur has nicely summed it up, that it's a molecule. The SGLT2 inhibitor has really made a huge difference as far as the management of cardiovascular disease is concerned, and So it was considered to be a diabetic drug, then it is cardiovascular, medication. It came as because it is going to decrease the cardiovascular outcomes. And then the nephrologist started feeling in love with this molecule, so this became a nephrologist favorite drug to delay the renal outcomes, adverse outcomes. So we will briefly discuss about the integrated multidisciplinary approach. So end of the day, it is the patient who would get benefit, and very rightly said by Dr. Mathur that glucose-centric approach should be not be the main approach, because we have seen that strictly controlling with insulin sugar, then also the outcomes were not as great as controlling with a particular molecule. So we have got SGLT2 inhibitor, which has really shown that it is going to change the way we manage our patients. So if you see the with the hypertension and dyslipidemia, uncontrolled HbA1c can put patients of diabetes at a higher risk of cardiorenal risk. And these patients have got, despite the treatment, a lot of patients would have significant unachieved target levels of HbA1c and higher risk of developing cardiovascular event, and most dreaded of that is heart attack. In next 10 years, 40% increased risk of heart failure. So diabetes is one of the main causes of heart failure, and nephropathy. So what we call diabetic nephropathy, which is very common in our country, and one of the major reasons for end-stage renal disease, dialysis, and renal transplant also. So there is a bidirectional pathophysiological interaction between the kidney and heart and in type 2 diabetes patients. So we know that if the heart suffers, the renal perfusion becomes lesser, and then the more and more, in heart failure, especially heart failure with reduced ejection fraction, more and more patients would have need for renal replacement therapy. And heart failure is the most common cause of hospitalization among people with diabetes. And remember, it's not only that you stabilize your patient and things are hunky-dory after that. It's not true. So each hospitalization with heart failure puts the patient at increased risk of mortality. So means that if the patient needed hospitalization, needed increased IV drugs, if needed, the oxygen and all, it means that the patient's mortality is going to be higher. The Indian Registered Event from Heart Registry also showed nearly 1,000 patients were there, and you could clearly see that the percentage of patients who were maximum were hypertensive patients and diabetic patients. So clinical and anatomical changes in HFpEF and HFrEF is something different. We know that the heart failure with reduced ejection fraction, heart failure with intermediate ejection fraction, and heart failure with reduced ejection fraction. So mid-range ejection fraction heart failure, where the ejection fraction is between 41% to 49%, behaves almost similar to heart failure with reduced ejection fraction, but heart failure with preserved ejection fraction, meaning thereby that the ejection fraction on echocardiogram is 50% or more than that. We did not have too many drugs which really benefited these patients. We had ARMY, which also failed to show the statistical significance improvement in HFpEF or preserved ejection fraction, though FDA has approved it to be used in heart failure with preserved ejection fraction. But we have data, liver dysfunction, coronary artery disease, myocardial infarction, because the diabetics are anyway stage 1 heart disease patients, and if they get a myocardial infarction, the systolic function goes down, remodeling and heart failure would happen, and that is something which is really, cascade which leads to early degeneration and the mortality in these patients. So once heart failure develops in individuals with diabetes, the outlook is really quite grim, and as much as 10 times more higher mortality compared with people with diabetes without heart failure, and a 5-year survival rate of only 12.5%. So that's a very gloomy picture. And those who get heart failure with reduced ejection fraction and repeated hospitalization, what we call frequent flyers, almost 50% of them will not survive beyond 5 years. You can imagine this is something which is more serious than many cancers. So prevalence of heart failure with preserved ejection fraction and reduced ejection fraction in diabetic patients, we can see that the preserved ejection fraction is something which is more prevalent, because but we don't really treat, because anyone till now the practice was that if the patient has on echo ejection fraction more than 50%, they would be thought that the dyspnea or breathlessness and all could be because of the pulmonary cause. A lot of them would go to pulmonologists, but if you do their biomarkers like NT-proBNP, ST2 and all those things, and echo with a well-trained echocardiographer where the EA ratio on echo, you should see that there is a significant grade 3 or grade 4 diastolic dysfunction. So these are the patients who would be classified as heart failure with reserved ejection fraction. And if you read the paradigm HF trial, this glycemia in heart failure patient is quite common. So you can clearly see that patients who are diabetic are almost nearly 40% of the patients, pre-diabetic 25% and undiagnosed diabetic 13%. You can see that 75% of the patients would have some of the other glucose maintenance abnormality, and that is the reason why they are having heart failure. So MACE outcomes in Canvas and Declare was non-significant in patients with primary prevention. So you can clearly see that these patients who have had, for primary prevention, it's not going to change the outcome. So dapagliflozin Declare data was very impressive as far as this. So if you see the Declare TB58 trial, that is dapagliflozin and cardiovascular outcome in patients with type 2 diabetes with prior mitral infarction. So in these groups, you can see that the cardiovascular death, MI or ischemic stroke was significantly reduced in the group where the dapagliflozin, that is the blue bar, is used. So definitely the patients who have had prior myocardial infarction, there the importance of using dapagliflozin is quite evident. There is a 16% relative risk reduction in major endpoints and also cardiovascular death or hospitalization due to heart failure. So you can see that whether the patient had mitral infarction or not, or if the patient had mitral infarction, the benefit was even better as far as the composite endpoint of cardiovascular death or heart failure hospitalization was there. Almost 19% relative risk reduction was there. And those who did not have prior mitral infarction, there also you can see that the heart endpoint was significantly lesser. So in patients who were on dapagliflozin. So DAPA-HF study was also again a landmark trial with dapagliflozin 10 milligram, and what you see in that, we'll go to the endpoint. There is a primary composite endpoint risk reduction in compared to placebo was 26% relative risk reduction was there in DAPA-HF trial. So that's again a very impressive data. And the worsening of heart failure component as a primary endpoint, that was again very impressive. The worsening of heart failure is delayed, and 30% relative risk reduction was there in patients who were on DAPA compared to placebo. And other standard of care treatment was there anyway. The cardiovascular death component of the primary endpoint, which is a very, very hard endpoint, was also reduced by 18% and significantly reduced relative risk of cardiovascular death or worsening of cost or re-hospitalization. And we must remember that hospitalization or re-hospitalization is a very, very important endpoint where the patient is eventually going in the direction of mortality. So if you see the number needed to treat was very less, just 21 patients needed to be treated to give this benefit, and relative risk reduction was 26%. You can imagine in these situations, the dapagliflozin was a real game changer. The renal composite of 50% sustained decline in eGFR, ESRD or renal death, again that was much more impressive. So if you see with the dapagliflozin, there was 29% risk reduction was there, and it slows down the worsening of kidney function, and that is what I meant in the beginning, that it is not only the diabetic drug, it is cardiovascular drug, and now the nephrologists are falling in love with this molecule because it is delaying the progression of end-stage renal disease. So if the patients have got diabetes or non-diabetes, if you see comparing the placebo versus dapagliflozin, dapagliflozin was significantly better. So meaning thereby that it is an automatic or auto-regulated anti-diabetic drug. If the patient had significant diabetes, it will decrease the HbA1c, it will decrease the blood sugar. But if the patient is non-diabetic but has got a chronic kidney disease, it has got a heart failure, you give this molecule, the patient will not go in hypoglycemia and will have the additional benefit of giving the cardiovascular benefit decreasing the hospitalization due to heart failure, and also would delay the progression to end-stage renal disease. So RB or no RB therapy. So somebody said that RB is a revolutionary drug, no doubt about that. But in those patients, whether you give RB or without RB, for some reasons you are not able to give patient RB, those patients who have got borderline blood pressure, if they don't tolerate the RB, in those group also the benefit was significantly better in favor of dapagliflozin compared to the placebo. And again, we monitor these patients with antiproBNP, whether the therapy is benefiting them or not, and you can clearly see that in patients who have on dapagliflozin, the important biomarker, that is antiproBNP, that went down significantly compared to those who were on placebo, meaning thereby it is benefiting. And also, there wasn't much safety concern as well. So a lot of people would say that the side effect of this molecule could lead to major hypoglycemia, amputation, diabetic ketoacidosis, cardiac gangrene, and other like volume depletion and all. But if you see the data compared to placebo, there is hardly any significant difference, meaning thereby that dapagliflozin would be a real, well tolerated and would not have these uncommon problems. So dapagliflozin prevents first and repeat hospitalization for heart failure. Both first and repeat hospitalization were reduced by dapagliflozin, leading to reduction in total admission for the heart failure. So you can imagine that the hospital beds are so scarce, and if you use the resources for hospitalizing these patients for no reason. And other thing which was very important was that the patient's first hospitalization was also reduced by 25% relative risk reduction was there, and the recurrent hospitalization by 29% relative risk reduction, meaning thereby that by decreasing the hospitalization, not only you are conserving the resources, but also the end of the day, the mortality of these patients would go down significantly. So long-term survival benefit dapagliflozin versus beta blockers and RAS inhibitors, you can clearly see that the dapagliflozin is a clear winner in them. So that is why we say, as Dr. Chauhan rightly said in the beginning, that we have got 4 pillars of heart failure with reduced ejection fraction treatment. We have beta blocker, we have got SGLT2 inhibitor, we have ARNI, and we have got MRA. On the fringes is sitting the ivabradine, the diuretics, and the other molecules, but that is not going to change the mortality. So these are the 4 molecules, and there were various approaches that which molecule should be started first. So I say that the patients who are really sick, those who have got low BP, there the SGLT2 inhibitor is the clear winner, because you can start it straight away without fearing about the drop in blood pressure or any other major issue. And then once the patient becomes a little better, then you can add on other things. But now we have got what we call slam bang approach, where all the molecules in the smallest possible tolerable dose should be started in one go and give the patient maximum benefit, because all of them are working on different pathways. If you look at the secondary prevention of MACE and heart failure hospitalization, also seen with empagliflozin and canagliflozin is also there. If you look at the data from Emperor, Empire outcome data or the Canvas study data, definitely the benefit was there. So mortality benefit can be seen with DAPA-HF versus Emperor reduced trial, and these are the things, but more or less you can see that they are still including it as a group has really done wonders as far as the hospitalization to the heart failure and cardiovascular mortality is concerned. If you look at the conclusion from DAPA-HF and Emperor data, they have got really one story to tell, that the heart failure is something which is a shared chronic phase of many cardiac disease. So that's the final common pathway, including ischemic heart disease, chronic obstructive pulmonary disease, and hypertension, and treatment options for HFrEF. And now we have got data for reserved ejection fraction also. And in all these situations, definitely the one answer to all heart failure is SGLT2 inhibitor, be it heart failure with reduced ejection fraction, mid-range ejection fraction, or heart failure with preserved ejection fraction. So I think this is a molecule which is really good. And we have got data from India also, that addition of dapagliflozin would to the patients who are already on ARNI would again make things better, especially in non-responders with HFrEF. So, if you look at we were saying that there are 5 main pillars. ARNI, beta blocker, MRA, SGLT2 inhibitor, and ACE and ARBs. So some people classify them into ARNI itself, so ACE, ARB, and ARNI as a single group. So definitely, this is the time where SGLT2 inhibitor has made a strong, data and would be considered to be one of the strongest pillars for that. In heart failure with preserved ejection fraction also, as I said, we have a lot of data from different trials, Emperor Preserve and also Deliver trial, where the patients who have got ejection fraction more than 50%, but other criteria of heart failure, there also, this is the only molecule apart from the MRAs which has shown to reduce the mortality. Even ARNI did not come to significant level to decreasing the mortality levels. So the SGLT2 inhibitors in preserved ejection fraction, we have to see that on echocardiogram, some of the trials have taken 50%, more than 50%, or more than 45% as ejection fraction. NT-proBNP should be more than 225, and the requirement for diuretic therapy due to the heart failure and recent heart failure hospitalization or urgent heart failure visit requiring IV diuretics, elevated filling pressure, or right heart or left heart catheterization, and structural heart disease by echocardiography. So this is the main inclusion criteria for preserved HF data, and preserved HF data did show that these SGLT2 inhibitors would be something to look forward, because there are not too many options available as far as this entity is concerned. So if you look at the quality of life, clinical, clinical summary also, these patients would do benefit. And then you need to objectively also can see that the molecules, the biomarkers like NT-proBNP, BNP, HbA1c, and systolic blood pressure, all of them would go down. So those patients who are not controlling well-controlled blood pressure, they are all the commonest cause. So uncontrolled hypertension is the commonest cause of HFpEF. So in those situations also, and the good thing is that most these, heart failure patients, be it HFpEF or heart failure with reduced ejection fraction, would be, because the fluid overload would be obese, would have higher weight than the recommended, body mass index. In those situations, it decreases the weight also, weight reduction by almost nearly, 1 to 4 kilograms, and by virtue of that, it will help in heart failure patients as well. So, summary was that dapagliflozin significantly improved the symptoms and physical limitations in patients with HFpEF in just 12 weeks, and treatment effects was large, and there were consistent effects in patients who were diabetic or non-diabetic as well, and it was very well tolerated. So the other good thing is that it's not that these patients would have to fear of side effect. There was no major side effect, and they would tolerate it really well. Clinical implication is that definitely we have got a molecule to look forward for HFpEF, and there are, so we don't talk about 5 pillars of treatment in HFpEF, because there aren't too many molecules which have really shown. Obviously, beta blocker is not a good drug in preserved ejection fraction. We do not see much benefit from ARNI or ACE inhibitor in those situations. We don't see much benefit from other molecules except for MRA and SGLT2 inhibitor. So if you look at the evolution of heart failure management, we see that the cardiorenal continuum is very, very important, and we need to give in HFpEF and mid-range ejection fraction all the 4 or 5 pillars of heart failure management. And in heart failure with preserved ejection fraction, the SGLT2 inhibitors and the ARNI would be something to be looking forward, and MRA can be given in those situations also. So the data from DAPA-HF and preserved HF data has really shown some hope in these group of patients, where we could have a misconception that mortality would be more in patients who have got heart failure with reduced ejection fraction, and it will not be more in heart failure with preserved ejection fraction, but that's not true. The mortality and morbidity is equally bad in patients who have got heart failure with preserved ejection fraction as well. So thank you very much for your kind attention, and we'll invite the chairperson and Dr. Chauhan to join the team from bombardment of questions.
Sir, thank you so much for a lovely talk on heart failure.
All three of you. एक कुर्सी और
Social fitness, I am 40
Get a chair there, please.
Please.
Get a chair.
Sir, it's fine, it's fine. Sir, start.
Thank you, Dr. Tulsi, for making me more comfortable, though I was comfortable otherwise also. So, what a lovely talk by Dr. Viveka, which always been there. So nothing to say positive part of that. Sir, well said, the role of SGLT2 and SGLT2 inhibitor in a heart failure preserved ejection fraction is very well highlighted by sir. And dapagliflozin in particular has proved a lot of beneficial effects which is other drugs being used in heart failure. So it was a wonderful talk. Thank you so much, sir. And now we request Sushil and go ahead for
I think we'll start with Dr. Tulsi, sir.
I need a mic.
Very, sir, if you can take this mic.
You go ahead.
No, go ahead. Ask question. We have a mic, sir. You ask.
So, what a wonderful talk, Dr. Viveka. So, incredible, consistent, positive findings. 3 very dramatic trials last 1 year. The Deliver, the Emperor, and the Chief heart failure trials all had a compelling story to tell. And what did they say? They said, use these drugs, the SGLT2 inhibitors, across all spectrum of heart failure. See, whether it is stage A, B, C, D, or NYHA 1, 2, 3, 4. So benefits accrue early and across the full spectrum of heart failure, irrespective of stage, as I said, and probably if we are entering a new era. See, when ejection fraction doesn't matter. See, when you use these drugs, and irrespective whether you have diabetes or not. Dr. Viveka, sir.
Yes, I think you have rightly summed it up that it's like, one size fits all. If you have a heart failure, you give the drug, it has got single strength, so it is going to benefit, and the trials also same thing was used. And beauty of this drug is that it is one drug which is automatic as far as the sugar control is concerned. If you have a high sugar, more glycosuria will happen. If the patient does not have diabetes, then also significant hypoglycemia is not there. But the beauty is that the reason why I like this drug is that not only in the heart failure, but heart failure with preserved ejection fraction, and also in patients who have got what we call type 2 myocardial infarction or ischemia, where the supply-demand mismatch is there, by virtue of auto-regulating the myocardial cells, metabolism and energy utilization, it works in those situations also. So there are many patients who have got coronary artery disease, they are non-diabetic, and they are non-revascularization because the diffuse disease are not willing to get it done. So in those situations we use these drugs, and that has really helped. I think it's a wonderful drug, and there are many other stories which would be unfolding in future because we don't really know much about it. Whatever we know, in last, half a decade, we have seen it's becoming, only a diabetologist drug. Initially, when I started, and Dr. Jahan will vouch for me, that when I was the biggest proponent of SGLT2 inhibitors as far as the cardiovascular drugs were concerned, and a combined meeting where the diabetologists would also come, they would criticize that, look, lo and behold, see, there are many side effects which you don't, foresee, but as a diabetologist, you could see it, and probably and they would say that the GLP-1 receptor analog would be the clear winner, but obviously, GLP-1 receptor analog will nowhere SGLT2 inhibitor as far as the heart failure patients are concerned. GLP-1 receptor analog has advantage in coronary artery disease as well as cardiovascular disease, no doubt about that. But as far as the heart failure, which is reduced ejection fraction and now in preserved ejection fraction, there is no match. So I don't see any near competition as far as the SGLT2 inhibitor is concerned in this segment.
So I will come to the GLP-1 agonist later on. But to further my interaction with you, so the prompt heart failure trial, which was presented in recently in the recently concluded conference of ACC, they said that there is a therapeutic inertia from the doctors to initiate these fantastic 4 drugs. So we need, cardiologists like Dr. Viveka to tell us about these fantastic 4 drugs to be used across this spectrum of heart failure. Tell us, sir.
Yes, I think you rightly said, and that is what we said that the 4 pillars when we say fantastic 4 or fabulous 4 drugs. And I think we need to emphasize this time and again. The reason is that there is an inertia that people feel that probably the patient will go into hypoglycemia. Somebody will feel that because the beta blocker they will go in hypo, the bradycardia and worsening of heart failure, because these all molecules have come against a strong contradictions. So if you look at the beta blocker at one point in time that was contraindicated in heart failure, and look now it is a cornerstone treatment. Similarly, SGLT2 inhibitor was not a cardiac drug, it was a diabetic drug. So people had an inhibition. So these misconceptions would take time to go away, but I think with the more and more educational programs, and thanks to 790 CME by Dr. Chauhan, this is getting hammered time again. So many hammerings would, get these inhibitions out, and probably we would be forcing molecule to use it.
So, Dr. Viveka, when I was interning, and I was in fact in charge of the ICU at Pochan, intensive coronary care unit, so what was heart failure treatment? See, Lasix and more Lasix, and Digoxin, and vasodilators probably. But now, look at the paradigm shift. We have 4 fantastic drugs. How do you sequence them, sir? How do you sequence the 4 drugs?
Yeah, so again, I said that there was initially, Professor McMurray said that we should start with beta blocker and then go to MRA, RV, then MRA and this thing. But now the consensus of latest ESC consensus is that we should go slam bang. So, because each molecule has got a different mechanism of action, and then we should give a smaller dose each molecule, and then we should be up titrating that. There are certain conditions where the patient may not tolerate, so that is why SGLT2 inhibitor is a wonderful drug, because it does not drop the blood pressure. Suppose we have got a blood pressure issue, we can start the SGLT2 inhibitor as first, and then MRAs, because that will also not affect the blood pressure, and then build it on RB and the beta blocker. So it is a slam bang technique rather than sequential technique of introducing the drugs.
So, as the editor-in-chief of JAC, Dr. Valentin Foster, said, probably individualized treatment, and what is this individualized treatment?
Yes, I think despite these molecules where most of the time, one size fits all, still individualization is important, because after all, each patient of heart failure is different from the other. Somebody would have more tachycardia, somebody would have renal dysfunction or cardiorenal syndrome, somebody would have more of a different class of heart failure. But remember, the heart failure, the moment you make a diagnosis, you should try and give all these molecules, so that biggest mortality benefit is in early stage, class 2 and early class 3. So you should not be waiting, and people, so if there is a data from heart failure class 4 data where army also did not improve in mortality. So we should not be waiting for too late to get the benefit. So I think you're right that we should be starting early. We should be starting all those together as far as we can come, and then we should individualize. So we should see which patient has got what clinical entity. Somebody has you give the army, and then the renal dysfunction becomes really significant. So in those situations, we need to withdraw the army, take a back seat with that, and give more SGLT2 inhibitor and beta blocker and MRA. So obviously, these things like cardiorenal continuum has to be honored, and based on that, we can titrate our therapy.
My last 3 questions to all of 3 of you, Dr. Chauhan, Dr. Mathur, and Dr. Viveka as well. So, Dr. Chauhan, HHS, DKA, and EDKA. Probably cause increased morbidity and mortality because of insufficient insulin, high levels of counter-regulatory hormones like glucagon, cortisol, growth hormones and catecholamines. So just probably a word on HHS, DK and EDK when you use SGLT2 inhibitors.
Sir, what do they mean, sir?
ये बिहार के पॉलिटिक्स की बात कर रहे हैं।
What do they mean, sir?
Okay, sir?
Can I request you answer your question?
Okay, sir.
Answer this question, sir.
So Dr. Mathur and Dr. Shrivan said to answer these questions, and where is Dr. Tuli?
Dr. Soli.
He will answer.
He said if there is any absentee, I should take over.
Yes, sir. Please, please explain.
Okay. Let me go ahead. And HHS is hyperosmolar hyperglycemia syndrome. DKA, we know, diabetic ketoacidosis, and EDKA, Dr. Ram, you know as well, euglycemic ketoacidosis, diabetic ketoacidosis. So these are present if you give SGLT2 inhibitors, and especially DKA when you have type 1 diabetes. So this SGLT2 inhibitors were previously 3 years back approved for type 1 diabetes. Recently it has been withdrawn. It's very disappointing, it's appalling, and it's devastating for patients who have type 1 diabetes to withdraw these drugs. Because as we know, Dr. Viveka probably would say that at least 50% of the type 1 diabetics have CAD. So these patients should have benefits of SGLT2 inhibitors. Dr. Chuan?
I would only say that till yesterday and till today morning I thought I knew everything about SGLT2 inhibitors, hyperosmolar diabetic coma, and euglycemic diabetic ketoacidosis. But there is always a roadblock in life, sir.
Right, sir.
And once you meet Dr. J.B.S. Tulsi, you understand that there is a long road to go, sir. Dr. Mathur likes to add something, sir.
Tulsi very well brought out. In type 1 diabetes, it has been always contraindicated, and people are not using it.
Sir, this was approved by the UA,
But not, it hasn't.
2019 for 3 years, recently withdrawn. It's appalling.
But it has not come into real practice.
So
This
this
is
is
talked about.
So
I just share with you, sir, I understand that distinct with an endocrinologist in USA. We talking about type 1 diabetes management. The hallmark remains insulin therapy till date. Control the diabetes insulin. No other OHA has proved a beneficial effect on that. That was
They have tried DAPA in type 1, sir.
But-
I think
you sit here. We'll have a talk. Come, sit here.
But it has not come into practice and not been approved. They are not using it. Maybe some trial must have approved it, but in clinical practice it will not in use.
Sir, Dr. Tulsi sir, has there been any recommendation of SGLT2 inhibitors in type 1, sir, just a minute, in type 1 diabetes by the Endocrine Society of India?
So the EU approved this drug in 2019.
Sir, by the Endocrine Society
No,
of
sir.
India.
No, sir. Even the US FDA didn't approve this.
So, sir, I would like to draw your attention to two things. In the last 10 years, in the last 1 decade, there has been one trial which has been prematurely terminated on account of entire pillar of treatment in type 1 diabetes revolves around insulin therapy. Everything else is hypothetical, is on trial, and they will keep, the indications will keep coming and being withdrawn. Sir, your comment on that?
Yes, I think what Dr. Tulsi is talking about. So recently there was a, from the European Society of Heart Failure and European Diabetic Association was a recommendation, but that had a caveat that the patients who are type 1 diabetic and also has got heart failure of any nature, then they should be given SGLT2 inhibitor. And so that was more for cardiac benefit rather than the diabetes control.
Excellent.
And even that has been withdrawn.
So it's really devastating.
I understand, but the recommendation has been withdrawn.
So, Dr. Chauhan, would you not like to give the benefits of this drug to type 1 diabetes, excepting for the DKA? And we know, you know, that we can manage DKA if you have sufficient insulin, if you are well hydrated. See, so there's not a problem with managing DKA.
Sir, the issue is very, the issue is a little different, sir. We are sitting in the capital of India, doing a wonderful CME on SGLT2 inhibitors. Moves are about 60 kilometers north, go to Sonipat, Panipat, and see the conditions, sir. You may not be able to do even serum ketones at night. And unless and until you can actually monitor and titrate them against the possibility of euglycemic diabetic ketoacidosis, I think it will be very foolhardy to try SGLT2 inhibitors in a type 1 diabetic and send him into some complications you cannot manage and not supervise. Not only manage but also not supervise. I am not a great proponent of, I would say, the novel medications in type 1 diabetes, sir. The cornerstone remains insulin. If we can understand the usage of insulin, if we can use it wisely in type 1 diabetes, I think that is good enough for our country for the time being. I would like to have a comment from Dr. Viveka, sir, on his usage of SGLT2 inhibitors for heart failure and for cardiac outcomes in type 1 diabetes.
Well, so I just mentioned it that has been something which can be thought of.
Yes.
To be honest, I have not really used in a single patient. So that is something which is...
not used it in a single patient.
No, we haven't used it.
So we have to be practical.
So it is something which has to be really done under close supervision, which is rarely in our part of the world.
So, my last two questions, Dr. Chauhan, all of three of you.
Sir, ask simple questions, sir.
Very simple questions, sir. Absolutely epic.
You remind me of my final year medicine viva, sir.
Dr. Chauhan, absolutely epic, imposing, incredible, and compelling.
इंग्लिश की क्लास है कि प्रैक्टिस की?
See,
Excellent use of vocabulary, sir.
मैं वही कहता हूँ।
thank you, sir. So, I was going to talk about the tirzepatide, Mounjaro, greater HbA1c reductions, greater weight loss. 90% of the patients achieved HbA1c below 7%. A great drug. See, presented in a recently concluded ADA, June 2022 at New Orleans, and published in BMJ as well. So once a week injection. So 15% patients dropped out in a 72-week trial, and what was surprising was 26% dropped out with placebo. So what a great drug. That is a peptide, sir.
Sir, any new anti-diabetic molecule which is an injectable molecule has to, sir, just hear me out, sir. We have 60 people here, and you are a great proponent of the newer molecules, and you have great knowledge of them. We always appreciate it. We must compare it with standard of care. Dr. Mathur beautifully said, in India, in 90% of the conditions, the second line drug remains sulfonylurea. We are still struggling to add a DPP-4 inhibitor as a second line molecule. In a country like ours, to introduce a molecule which has just been approved by FDA for diabetes control and for weight reduction, and a molecule which will cost about 7,000 rupees one injection in our country is something which we have to really be very, very careful about. You can have great molecules, sir. The problem is what Dr. Viveka told us about a great lipid molecule called Repatha. What happened, sir, to that molecule? How many times have you prescribed it to your patients? And why did we need a molecule called bempedoic acid, an oral medication to achieve LDL goals beyond statins? I think Dr. Viveka would summarize it better. This molecule, any new anti-diabetic molecule, I think you would summarize it better for us because you know it better than us. The molecule, first of all, is not available in India as yet, if to the best of my knowledge. It's not available in India.
Not available.
Not available. None of the companies has been able to market it in India because of the great price that, at which it will come. Sir, I would like to have your knowledge on that and also your experience with Repatha, the great anti-lipid molecule, sir, which you taught us and which you told us that you give it only, twice in a month. And PCSK inhibitor, the great PCSK inhibitor, PCSK9 inhibitor. Sir, your comparison of the two things.
We are talking about Repatha, not about Repatha.
Yeah, so basically,
These are comparable things. We must talk about it.
it's like, the drug has to be cost effective. So either the number needed to treat is very small, then that will make a huge beeline for that particular drug. But I think if you look at the science, we need to always respect a newer molecule because over the years they will become a cheaper drug and yet the cost benefit and the mortality benefit and the longevity benefits are significantly better. So I would put them at best as to be watched carefully for future use. And I fully agree with Dr. Chauhan also that it has to be really something which has to be drug of masses rather than drugs used by the kids and these what we call people who can afford a jet.
My last question
Sir,
on...
Dr. Tulsi, can I just add one thing?
Please, sir.
About use of the drugs which you talk newer drugs. All of us been practicing diabetes. I've been practicing periphery also. On Sunday I was in a camp in a small town where I seen about 60 patients of diabetes and thyroid. 80% of people are not on SGLT2i. They were only on metformin, sulfonylurea, maybe somebody were taking pioglitazone. SGLT2 inhibitor, DP4 inhibitor were there, but out of 2 patients I saw them, they were given a double. Sir, let's talk about the country as a whole. New drugs is good to learn, and you are a voracious reader, knowledge, are excellent, but cannot be practiced in a bit. So I would like to share with you, sir. We have been practicing up to grassroots level, today doctor, but we practice with that.
My last question on sotagliflozin, SGLT1 and SGLT2 inhibitors. Probably a wonderful drug again. So, Dr. Viveka, would you talk about
regarding its usage in diabetes or heart failure?
In heart failure as well as in diabetes.
And cardiovascular outcomes.
Absolutely reduces pace. Dr. Viveka?
Yeah, so I think still we need to have more data, but it has shown that it will decrease the cardiovascular outcome like SGLT2.
So the SCORE trial said everything about it.
Yes, so it's one of trials, so something like it was not as powerful as like paradigm HF data that one trial will make the guidelines, but I think we need more data to make it into. And the other thing is that the SGLT2 inhibitors are not doing bad either, so it has a tough competition.
But SGLT1 plus 2, as we know, SGLT1 probably reduces glucose absorption from the gut and the SGLT2 reduces absorption from the tubules. So probably dual effect and probably better effects, reduces pace, the SCORE trial said so. Thank you, sir.
Yeah. After exhaustive questions and say maybe people may be tired of say hypothalamus use hippocampus. Sir, let me make it light. Sir, Dr. माथुर ने जब प्रेजेंट किया था डॉक्टर बाबू का, तो उसमें MARD मर्द को दर्द नहीं होता, मुझे ऐसा कुछ लगा. तो मर्द का मतलब ये था कि माइल्ड एज रिलेटेड डायबिटीज. This was probably the only one entity where HDL was high. So in India, we are known to have low HDL, high TG. So are we protected from murder? हम मर्द नहीं है क्या?
Not be able to explain further on that. Dr. Mathur's line. But HDL high is normal in some patients which have been higher but diabetes is there, but they are not. I mean, they may be obese or they may not be obese. I have not been able to explain further. So she will talk about.
Just a minute, only 2 lines. Dr. Tulsi would be able to elaborate it in pages, but some subtype of diabetes in elderly people is not associated with insulin resistance, with great elevated insulin resistance. You would understand from our basic talk of last 15-16 years that we have put in, insulin resistance is directly related to low HDL cholesterol. It is insulin resistance which drives fatty acids. Higher fatty acids are again related to insulin resistance. So 2 things you must watch out for in a diabetic. Consistently, low HDL, higher fatty acids. That means that there is insulin resistance. You can say without doubt that this patient needs some sort of treatment for insulin resistance. But there is a subtype in our elderly population, even in India, that they do not have elevated insulin resistance, too much of insulin resistance or elevated HOMA-IR. So these are the people who have good HDL cholesterol.
So the corollary to the same is, if you have low insulin, you are more likely to have retinopathy. If you have high insulin, it's more likely to have CKD. Agreed, sir?
Yes, sir.
Sir. So, although it was discussed many-fold, what I can imagine, whether preserved or not preserved, reduced ejection fraction. So, dapagliflozin or SGLT2, any one of them, so does it act same way or has it some predominance in any of them?
I think I would subclassify your question, sir.
Yeah, please.
We have some very impressive data from the very well constructed trials. We have data from EMPEREG, and then we have data from the DAPA trial, and then we have data from the Canvas trial. All right, sir. Now please understand the differences, and I would like Dr. Viveka sir to make it better, for us. Sir, in EMPEREG, we had a population which had reduced HHF, which had 15% reduction in MACE, and reflected in 32% relative reduction in cardiovascular morbidity and mortality. Now, we had this trial on DAPA, which showed great benefit on HHF. There was no benefit on MACE. There was no benefit on MACE. There was no benefit on cardiovascular mortality and morbidity. And then we had this great trial Canvas on canagliflozin, which showed great advantage on HHF, which had actually significantly more reduction in MACE than even in EMPEREG. But unfortunately, again did not show any reduction in cardiovascular mortality and mortality. Sir, can you explain this for us?
Yes, sir. That is why it is said that there are some class effect, and that class effect is mainly into hospitalization due to the heart failure. But if you look beyond that, the certain molecules give more benefit. So those patients who are high risk cardiovascular, there the empagliflozin has shown clear benefit. Those who have got more kidney protection, there the dapagliflozin and the canagliflozin has shown real benefit. So I think we should not say that all SGLT2 inhibitors are same, and that is the reason why there was certain ramagliflozin which said that it is the SGLT2 inhibitor would have same benefit, but it has not really stood the test of these benefits.
So probably EMPA has a greater selectivity towards SGLT2 inhibitors, and CANA has the least selectivity towards SGLT2 inhibitors.
So my last question is, we were talking about Fantastic Four. Can I know, for the benefit of all my friends, what are the Fantastic Four? Because, no sir, you know, I know, many of my friends may be having some doubt. Which are the Fantastic Four? beta blockers, ACE, RB, ARNI, MRA, and SGLT2. What are the fours?
Yeah, so I think that's right. So beta blocker, SGLT2 inhibitor, MRA, and the RB. So these are the fantastic.
Diuretics are no longer fantastic.
ACE
No, diuretic.
ACE and ARB are.
RB, ACE and ARB is one group.
Okay. So,
So that is why somewhere they say that fantastic 5 because ACE is different from the
पांडव तो पांच ही थे, पांचों ही रहने दो
I think this may be indirectly supportive to what Dr. Tulsi said. If a drug, new drug comes and if it is approved by Drug Controller General of India, DCGI, whatever may be the cost of it, if it is approved, then we must tell our patient that this is available, this is recommended drug, but if you can't afford, you have to give consent, I can't afford you. You must offer the latest drug to all the patients if it is approved by DCGI. That is my concern.
Sir, I would,
Otherwise you can't.
give me just. So my own brother-in-law, my own real brother-in-law is truly statin hypersensitive. He cannot tolerate statins. He was in US, was given Lipitor, and was in extreme myalgic pain for 2 days. He came back to India. He had a procedure done. He had a left circumflex artery blocked, and he was stented. And when he was given the first dose of statin, 80 milligram, he had terrible issues. I waited for 10 years, kept asking Dr. Viveka, sir, is there a response? He recommended me ezetimibe. He told me, yes, you asked him for intensive lifestyle modifications. He did. When this great molecule came, sir, Ripatha in India, I asked my brother-in-law, take this injection, 18,000 rupees injection every 15 days, I'll get some discount, 14,000 rupees. He said, जी कल से walk करने जाऊँगा. कल सुन लीजिए, आपके सवाल का ही जवाब दे रहा हूँ सर. आपके सवाल का ही जवाब दे रहा हूँ. जवाब सुनने की तो आपने सवाल तो पूछ लिया, उसका जवाब भी तो सुन लो ना. I involved my wife, my father-in-law, and my sister-in-law. In front of them, I talked to him and I told him, please take this injection. He said, जीजा जी कल से walk करने जाऊँगा. अभी सर 5 साल हो गए कहते हुए, अभी वो वॉक करने नहीं गया. ठीक है, LDL कहीं पे भी टारगेट पे नहीं है. सर दिस मॉलिक्यूल केम बेंजोइक एसिड, मैंने लिया, उसको दिया, मैंने कहा ये खा. उसने खाना शुरू किया. ऑलरेडी सर 1 महीने के अंदर उसका LDL जो है पहली बार. सर अंडरस्टैंड द अफोर्डेबिलिटी ऑफ द मेडिकेशन. आई हैव नथिंग अगेंस्ट डॉक्टर तुलसी सर. ही इज अ ग्रेट टीचर ऑफ द इनोवेशंस, एवरीथिंग न्यू. But unless and until you are able to afford the medication, this does not make sense. We can talk about it the whole night, but the patient has to afford it out of pocket. And if he doesn't have a reimbursement, there is no point talking about a molecule for 10 hours when even 10 patients in 1 year are not able to afford it. Sir, my brother-in-law can afford the medication. Let me tell you, he is on a good package by God's grace. He didn't take the medication. He said, कल से walk करने जाऊँगा. ठीक है? अभी उसका LDL target achieve हो गया 1 महीने के अंदर 180 मिलीग्राम बेंजोइक एसिड पे. He is not going for a walk. Please understand, all of you, I request all of you that it is great learning here, or it's a great platform, but the medicine has to be affordable. Sir, your comment on that?
Yeah, so I think the whole world, even in US, people are not able to afford SK9 inhibitor. So the healthcare, so when I was in India, and then I thought that when you go to Western world, there the affordability is not an issue. But the same, big institutes, the world famous Oxford and Cambridge, they were also struggling for funds, and the similar story was there. So scale of struggle is different, but definitely the whole world is, short of funds. So bottom line is that, even if the healthcare is supported by the government or insurance or anything, but affordability is an issue, and that is why the whole world is fighting to make healthcare more affordable. But they are hitting the wrong place. They are hitting us rather than the cost of the medication and the other issues, which is increasing the cost of the medicine. So I think the healthcare would only forward or not if they are affordable.
I agree with both of you.
my only point was, if it is approved drug in India, we must offer it, because sometimes I have seen poor patients also. Sometimes their employers come and they say, why didn't you prescribe the best drug? We could have